From the American Academy of Pediatrics.
Counseling families about vaccines is a major part of what we do.
New guidance from the AAP shows those conversations are important in more ways than one.
Most parents who are hesitant are just that. They're hesitant, they're uncertain, they're not directly opposed.
Plus, new research about marijuana use in breastfeeding shows we need more research.
We still have a lot of work to do toward standardizing our approach for these newborns with perinatal marijuana exposure.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a look at counseling families who are hesitant about vaccines.
Joanna, we were talking recently about your newborn, Zelda, and how much you worry about infections with her being so little. How are you managing those worries?
Well, it's hard when you have two other kids in the house and everyone is sharing germs. Sometimes I don't even know when one sickness ends and another begins. So I just did my best to prepare for having a baby who isn't vaccinated against anything by making sure everyone else is and trying to give her a cocoon of protection.
You know, I know you are so excited to get Zelda vaccinated, and to be honest, I still have a hard time understanding why some parents don't vaccinate their children completely and on time. As a pediatrician, knowing that a child is under or unvaccinated makes me incredibly nervous.
Same here. I'll feel so much better when Zelda gets all her routine vaccinations. And I have trouble relating to and sometimes talking to parents who hesitate to immunize.
Me too. Our guest today can help us learn how to relate and communicate better, Dr. Jesse Hackell. He's co-author of a clinical report from the AAP, Strategies for Improving Vaccine Communication and Uptake.
Dr. Hackell is a retired general pediatrician and immediate past president of the New York State AAP Chapter 3 and chair of the AAP Committee on Practice and Ambulatory Medicine. Jesse, welcome to the show.
Thank you. It's a pleasure to be here with you.
So, Dr. Hackell, I know, especially when we had COVID, it seemed like fewer children were up to date on necessary vaccines. Where are we now?
Well, you're right. With the COVID outbreak, there was a dramatic fall off during the first several months on the routine well visits. And since vaccinations are part of the well visits, kids who missed those well visits were behind on their vaccines. However, starting probably in July, we made a major effort through the Academy to increase the number of well visits, get people back on track. We haven't completely recovered from those missed vaccines, although we've done better over the past year or two. That's within the U.S., but worldwide, there are still a number of children who are missing vaccines and who have not yet caught up.
In the report, you talk about attitudes, intentions, and behaviors. Can you tell us a little bit about these concepts and how they apply when it comes to immunization?
Sure. The attitudes are what we discuss as the parent or the individual's confidence in the vaccines, whether they are confident in them and using them, or whether they're hesitant about using them. And that's their attitude. It's often influenced by their perception of the disease and the risk. You know, the risk of the disease being more severe in the parent's mind leads them to being more confident in using the vaccines. So the attitudes are what they think. Their intentions are how they plan to act on those attitudes. If they're confident for the vaccine being necessary, then their intentions are to go ahead and get the vaccines for their children. And once they've developed that intention, it directly influences their behaviors, which is the actual uptake of the vaccine. And so what we like to say is that the attitudes influence the intentions, which then determine the behaviors.
So we hear a lot about vaccine hesitancy, and you mentioned it too. Is that an attitude then?
Yes, it is. Vaccine hesitancy is an attitude. It's got lots of causes, but in the end, the result is somebody who wants to either not get the vaccine or delay it or change something from the routine schedule.
Let's talk about those causes. What makes families hesitant?
Sure. As I said, there's a host of reasons that parents may be hesitant, ranging from really simple ones about not wanting to hurt their child with a needle and see the child cry. But they go deeper. And we have parents who are hesitant about giving a child vaccines for a lot of reasons. They may be concerned about the safety of a vaccine. They may be concerned about its efficacy. Parents today have generally not seen many of the diseases that we vaccinate against. They haven't seen measles. I know I haven't seen a case of measles since my training. And, I'm in the healthcare seeing kids every day. But parents who aren't familiar with the diseases may not recognize the risk of damage that these diseases can cause. So they're worried about safety, they're worried about efficacy, they're worried about necessity. In general, they're not worried about costs because we can make vaccines available to children with or without insurance. But those are the common things that we hear. The other things that we hear less commonly today are about risks of things contained in the vaccine, such as thimerosal or mercury, which despite continuing to be a concern of parents, we haven't had vaccines containing thimerosal for pediatric use in many, many years. That's not a risk that we need to consider at all. And then some parents still revert to older studies which have been disproven and which have actually been withdrawn, suggesting a risk of autism. There's no connection whatsoever between receiving vaccines today and the development of autism. And I want to make that entirely clear, even though I believe much of our audience is fully aware of that.
Jesse, you mentioned that you haven't seen a case of the measles since your training. Now we're seeing more and more measles cases with the outbreaks. And, pediatricians say vaccines, because of this, are a victim of their own success. People never meet someone who had, let's say, measles or polio, and they start to think the vaccine isn't necessary. Is there truth to that?
Not at all. There's no truth to that whatsoever. We know with measles, for example, that there is still measles disease circulating in the world. We've seen imported cases in the country over the past several years, an outbreak in New York where I practiced a couple of years ago with several hundred cases. And throughout the rest of the country, we've seen these outbreaks. The reason we're only seeing them sporadically is because the vast majority of people are vaccinated and cannot contract measles and pass it on and create an epidemic. And the number that we look for is to have at least 95% of the population vaccinated, and that would prevent the spread of an imported case of measles. The problem is, as we fall below that 95%, and we're now somewhere in the 92 to 93% range nationwide, an imported case has the potential to cause a significant epidemic. And, that doesn't change despite the fact that we haven't seen much. In communities where there's very low vaccination rates, an imported case can spread and affect many people. And we've seen that fairly recently in some outbreaks, I believe in Ohio and elsewhere. So we still have the risk of an imported case of measles spreading if there are a significant number of susceptible individuals. So yes, keeping the population highly immunized is the best way that we can prevent those occasional cases from becoming more widespread.
And Jesse, I know you best probably as an expert in healthcare finance. Can you help us quantify some of the most important costs of vaccine hesitancy and refusal?
Sure. We look at this in terms of several different stakeholders in terms of healthcare financing. When you have an outbreak of measles, the cost is borne by several different groups. Obviously, it's borne by society as a whole. In that outbreak in New York, which I believe was in 2018, the direct costs of responding to the epidemic were over $8 million, and that needed to be borne by the local health departments. That's not something they normally budget for, and that money has to come from other services, but that includes contact tracing, emergency immunization clinics, isolation, things like that. So those are some direct costs. We find that the individual bears costs as well when there's an outbreak. Obviously, think of the child who's sick with the disease that he or she did not have to have. There's a cost there, even though it may not be totally quantifiable in dollars. But how about the parents and caregivers of that child? When you have a child who's sick at home, you're not able to go to work, and you lose your work days and you lose your family income for the days you're required to care for that child. That's particularly a problem in families who have lesser resources to begin with. They may not have the ability to make alternative arrangements to care for a sick child and are much more likely to suffer the loss of the income. But it impacts all the families because they do incur additional costs in dealing with illnesses. Now, you could say that happens for any illness that a child may suffer, and that's true. But at least the illnesses that we can prevent that loss. While we may not have a lot of sympathy for the insurance companies and the payers, they too face increased costs from an outbreak. When you have increased illness and you have kids with measles being hospitalized, their costs obviously go up significantly. We know that $1 spent on immunization saves at least $3 in direct costs to the healthcare system. And when you consider the indirect costs, such as loss of wages, $1 spent on immunization can save as much as $10 in costs overall to society. And then the final stakeholder who bears the costs of vaccine-preventable disease outbreaks is the pediatrician. Pediatricians, if they see a case of measles in their office, that office needs to be shut down and cleaned because the measles virus can circulate in the air for 2 to 3 hours, even after the child who's got it has left the office. And that disrupts your workflow. It disrupts your ability to see patients in the office and to provide care for other kids in the office. In addition, when we're dealing with hesitancy and parents who have concerns about the vaccines, pediatricians can spend an inordinate amount of time discussing and counseling them about the need for the vaccines. And that time becomes much worse when we're in the middle of an outbreak that needs to be controlled. So the costs are borne by society across the board and by the healthcare system, and they're not insignificant.
And say you're with a vaccine-hesitant family in your clinic and you're engaging them in a more extended conversation about vaccines during your busy office hours. How much are you getting reimbursed for actually talking to that family about vaccines?
Well, we're getting paid for vaccine administration. And spending the time talking to a parent about the vaccine, about the reasons, the risks and benefits, and potential side effects, that's part of what we do as part of the vaccine administration. The hooker here is that in most cases, if the vaccine is not given, there's no administration to be paid for. And so the time that you spend discussing this with a family is time that's uncompensated. It's time that's spent away from your other duties and your other responsibilities, and yet without compensation.
And how do we respond if a family says, yes, they want their child to have all the vaccines, but they just want to spread them all out?
Well, the schedule that's been approved by the Advisory Committee on Immunization Practices and by the AAP is approved for a reason. It's approved because that's the schedule that has shown evidence for both safety and efficacy of the vaccine. No other schedule has been studied in the same way to show that it would be equally safe and equally effective. And there's certainly no evidence that shows that delaying a vaccine makes it safer for a child. In fact, delaying a vaccine raises the issue of timeliness of vaccination. For every day that a child is unvaccinated when they could have been, that's another day they're exposed to these preventable diseases and running the risk of contracting the illness and suffering the consequences.
How would you advise I should answer when a parent asks me, so, Doc, how do you know these vaccines are safe?
Well, there's a lot of information on the vaccine development, testing, and licensing process that's available. Vaccines, despite what people may think with the way the COVID vaccine was rapidly developed, despite what people may think, no vaccine, and that includes the COVID vaccine, is released for public use without testing that follows a very strict protocol. Vaccines are tested first in very small groups of people, called a phase 1 trial, to check that they're safe. goes to phase 2 trials to determine efficacy and optimal doses, and then it goes into a large trial in phase 3 where it determines both safety and efficacy in prevention of disease. And so that's even before a vaccine is released for use. After vaccines are released for general use, we don't simply forget about them. The results of vaccination and the impact on disease is continually monitored through several programs run by the government and the CDC to assure that we can detect even rare side effects of vaccines and to determine that, in fact, they are efficacious as we believe they are.
And to get a little bit deeper into the weeds on that, can you tell us a little bit about the difference between the Vaccine Adverse Events Reporting System and the Vaccine Safety Data Link run by the CDC?
Yes, the Vaccine Adverse Events Reporting System, known as VAERS, VAERS, is a voluntary reporting system that anybody can report to. Providers should be reporting any side effects, but anybody who receives any medical treatment can report any adverse effects to VAERS. It's a very good tool for assessing widely the response to vaccinations, but it's really a terrible tool that's not even indicated for use at determining causation. What VAERS does is points to a signal, something that we should be addressing and looking at in more detail. And reports to VAERS are reviewed, more information is sought, and an effort is made to determine whether, in fact, there is even a relationship to the vaccine before we go any further in changing recommendations. Now, the Vaccine Safety Data Link, known as the VSD, is a consortium of a number of large healthcare systems, and they continually monitor their patients in response to the administration of vaccines. So there we have a more proactive monitoring system where vaccines are given and adverse effects are sought by interviewing and discussing with the recipients what's gone on. So it is a much more rigorous system for determining relationship and causation.
You know, I always tell my residents when I'm working in the well baby nursery and the hepatitis vaccine is due, and now I'll have to do this with the RSV monoclonal antibody injection, I say just walk in and tell the family that vaccines are part of our standard newborn care and the baby is going to get vaccinated. Does this presumptive approach work? Is there science to back me up here?
Well, there is. There's a fair amount of science that shows that when you take a presumptive approach to the vaccine, as you said, just announcing to the parents that this is what your baby is due for and this is what we're going to do today, there is a much greater uptake. It has to do with decision-making theory. If the default position is that the vaccines will be given, most people tend to defer and accept the default position. If you take a more permissive approach of asking the parents whether or not they want a vaccine, you've taken the default choice away from vaccination, and that leads to confusion and uncertainty on the parts of the parents and may lead to a greater number of them hesitating or refusing the vaccine. So the presumptive approach is a key tool that we use when we're discussing vaccines with our parents.
You know, we've been talking about what we do one-on-one with patients, but are there steps we should be taking to lessen vaccine hesitancy and refusal in our communities?
There are, and we can do that. I mean, much of what we do as pediatricians is one-on-one with the parents when we're seeing their child for their vaccine visit. But we need to enlist community support as well. And it goes again to making vaccination the default position. We need to work as pediatricians with community leaders, religious and social group leaders in our community to help make sure that vaccination is in fact considered to be the standard practice or the default position. And, you know, when parents come from different places, different backgrounds, different experiences from their pediatrician, the messaging that may come from the pediatrician may be a little bit difficult for the parent to accept. accept. But when it comes from a community member and somebody with whom they've shared the same past experiences, it may be a more powerful message. There's not a single way of helping to develop confidence in vaccines in parents. There are multiple tools that we can use.
And speaking of tools for parents, let's say you've really tried to convince a family to vaccinate and they've refused. Is it okay to dismiss a patient from your practice if they refuse vaccines or even don't want them on the correct schedule?
Yeah, this is a topic that's fairly fraught. And there's a lot of discussion and there's a lot of opinion on both sides of the issue. There's some suggestion, and it's mostly anecdotal, that if a pediatrician takes a strong stand and the family has a relationship with the pediatrician, that the parent can be convinced to go ahead with the vaccine. And that's based on our longstanding personal relationship with the family. The other side of the coin is that the risk of dismissal impacts the health care for the child based on a decision that the child is not making by themselves. And, we're pediatricians and our main goal is to assure good care for our children. That said, there are times when the breakdown in the communication is so severe that it can lead to a breakdown in trust and a breakdown in the relationship between the doctor and the patient. And at some point, it may come that the family is no longer confident in the recommendations of the pediatrician in general, not simply about vaccines. And in that situation, it may be appropriate to dismiss a family. Now, that's not something we do lightly. I think in our practice, we probably dismissed a handful of patients over 10 years that we've had that policy. And you can't do that without assuring that there are other sources of health care for the child. If you're the only source of care, it's better to compromise your beliefs to make sure that all the child's other needs can still be met. But in areas where children are well served and have a variety of choices, it may be acceptable. But it's something that needs to be agreed upon in the practice, and it needs to be something that is done paying particular attention to state laws about abandonment of patients. So it doesn't happen often. It's something that pediatricians can do, but we do strive tremendously to avoid doing it. None of us do it in the first or second or often even the fifth conversation. It's only something that we get to after a long trial, a long number of attempts to convince the parents to vaccinate.
Well, this has been an enormously enlightening conversation, Jesse. You got one last shot to address our listeners. Any takeaways before you go?
Yeah, I think the most important thing I can say is that no matter what a parent's attitudes towards vaccination are, communication is key. Talking to a parent about vaccinations, just like anything else, is a really wonderful opportunity to build relationships with parents and families. The fact that we want to vaccinate our patients, the fact that we vaccinate ourselves and our own children and grandchildren sends a really strong message to parents that we're committed to it and believe strongly in both the safety and the efficacy of vaccination. And having these conversations with parents who are hesitant can be frustrating, but in the end, most parents who are hesitant are just that. They're hesitant, they're uncertain, they're not directly opposed. And spending the time helping them understand the safety behind vaccines, the reasons we vaccinate, and the benefits for their children is time well spent, both in terms of getting kids vaccinated and in having a good relationship between us as pediatricians and our families that we care for.
Dr. Jesse Hackell, thank you so much for talking with us today.
It's been a pleasure. Thank you for having me.
To read the clinical report, Strategies for Improving Vaccine Communication and Uptake, go to aap.org/podcast.
Coming up, we'll look at research into how different hospitals handle perinatal marijuana exposure in infants.
I know we get a lot of research surveys that hit our inboxes, but I tell you, David, I always try to do them because I'm like, here's something I could do to help. Even though at times I don't see the results, I want to be able to participate.
I totally agree, Joanna. If we want reliable data for making medical decisions, the least we can do is to contribute our points to the graph.
And I know we all have our own feelings about these online surveys. And can I just say that one feeling I have for today's podcast is excited? Because one of those surveys I did as medical director of our newborn nursery was published in Pediatrics, and we get to review the results of it together today.
Oh, that is so cool. You must be part of the paper Marijuana Use and Breastfeeding, a survey of newborn nurseries. And what's going to be even more engaging is having Dr. Pearl Chang, the lead author of that paper, on to talk about it.
Dr. Chang is an assistant professor of pediatrics at the University of Washington and practices hospital medicine at Seattle Children's Hospital, where she also does work as a researcher at their Center for Clinical and Translational Research. Dr. Chang, welcome to the show.
Thank you so much for having me. It's a pleasure to be here.
So let's start with your motivation for doing this study. Why survey newborn nurseries about marijuana and breastfeeding in the immediate postpartum period? What were you thinking you might find?
Yeah, well, I first want to just acknowledge my co-authors, Dr. Nira Goyal and Dr. Esther Chung, who really spearheaded the study. I was personally inspired to join their efforts because I was seeing more and more newborns in the nursery with perinatal marijuana exposure. And I just didn't know if my management of these babies and their families was in line with all my other nursery colleagues out there. And so in this study, we were hoping to find out more about what hospital practices are like in the US regarding perinatal marijuana use and breastfeeding, and whether these practices were associated with clinician knowledge about marijuana use, any association with geographic location, as well as state legalization of marijuana.
And I get emails from the Better Outcomes Through Research for Newborns or Born Network. But for those who don't, what is the Born Network and how did you recruit for this study?
The Born Network is a research collaborative of academic and community setting nurseries across the U.S. I will advertise that their mission is to improve the evidence base for the care of newborns, specifically term and late preterm newborns. And the way we recruited is we emailed our survey to the site leads of each nursery in the Born Network. So thank you, Joanna, for filling out our survey. If there's anyone else listening to this right now, thank you so much for filling out our survey back in 2021. We couldn't have done this study without you.
And for those of us who didn't fill out the survey, what kinds of questions were you asking?
Yeah, we asked the basic demographics questions. In addition, we asked about Born Hospital's practices for mothers who do test positive for marijuana at time of delivery. So this included how they approached breastfeeding. Did they contact social work? Did they refer for child welfare services? We also asked about the site lead's knowledge and attitudes regarding marijuana use.
And when you began to review the responses, what did you find? Were nursery directors well-versed in the potential harms of marijuana exposure in pregnancy and when breastfeeding?
Yes, we found that for the most part, the site leads expressed great confidence in their knowledge of marijuana, both in the overall effect of marijuana as well as perinatal exposure. And we found that in general, their knowledge level was quite high. There were some knowledge gaps. Some were not aware of the potential harm of marijuana use on the developing fetus. So in terms of potentially affecting birth weight, things like that.
So we recently addressed this issue in our own newborn nursery, and so I am especially curious to learn. Knowing that marijuana could affect the infant both in utero and then subsequently when breastfeeding, were all newborn nurseries generally counseling families and birth parents with marijuana use similarly, or were there big differences?
We definitely found some differences. In the folks who did fill out the survey, we found that about 16% of nurseries selectively or universally discouraged families from breastfeeding altogether. We also found that only about 30% of Born hospitals who filled out the survey were providing resources for marijuana cessation for mothers who test positive for marijuana at time of delivery. So we definitely found some differences that we think in the future really need more research and standardization for how to best approach these newborns.
That's interesting and maybe a little concerning that there is some wide variation in pediatric practice here. So what do you think accounts for that? Why are different professionals approaching this differently?
Yeah, that's a great question. I think we actually need more studies, specifically of pediatric providers surrounding this issue. Most of the studies published are of OBGYN providers and why they approach the counseling of mothers with marijuana use differently. And I think our study begins to address that a little bit, but does not go in deeply enough. And if I had to speculate, I would suspect it's a combination of perhaps just some uncertainty about the evidence base behind marijuana use and how it affects the infant, their exposure through breast milk, for instance. I suspect there's also just, understandable discomfort over asking and talking to mothers about marijuana, particularly if you're in a state where you are legally obligated to report these families to child welfare services.
It seems like we still have a lot of work to do on marijuana and breastfeeding and how we should be counseling families. And we want our listeners to educate themselves on what they can do better in pediatrics and, of course, read your paper. So what last takeaways do you have for us before they go pick it up?
Yeah, I think the number one takeaway is we still have a lot of work to do toward standardizing our approach for these newborns with perinatal marijuana exposure. And hopefully someday we will be able to have a more standardized approach that is not only evidence-based, but also family-centered and equitable. And I hope folks will read our paper and be inspired to do more research surrounding this topic, or at least have further discussions at their local institutions about how to care for these newborns and their families.
Dr. Pearl Chang, thank you so much for joining us today.
Thank you for having me.
To read the article, Marijuana Use and Breastfeeding, a Survey of Newborn Nurseries, visit our website at aap.org/podcast. At the end of every episode, we'd like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, I have an hour-and-a-half drive home from Goldsboro when I do my hospital shifts there, and every now and then I see something extraordinary. Today, I looked up at what I thought was yet another buzzard, but that buzzard had a white head and the most spectacular wings. And Joanna, it was a freaking bald eagle.
That's so cool.
I was amazed. I wanted to pull the car over and take a picture, but I was going 80, and it seemed unwise.
That's really fun. We have bald eagles at the lake we go to in Connecticut every summer, so they're a really cool bird to see.
Spectacular.
Yeah. My Say Ah is that my baby knows who I am.
Really?
And that's always she started really smiling and starting to track, and she, I think, knows my voice.
Ooh,
so
sure
it gets more fun
voice.
when they start to recognize you. So I'm excited
that's
for that.
so fun. Zelda is catching up with all of our listeners, Joanna. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll have the March edition of First Up.
We'll also talk about disaster preparedness with two pediatricians whose communities have survived hurricanes, earthquakes, and wildfires. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.